Inova is a 5-hospital, large ambulatory health system in Northern Virginia. We serve our community. We have a large community health contingent of clinics and programs that are in the neighborhoods that we serve. We are onboarded with the platform. We make referrals. We actually onboarded essentially our entire clinical team all at once. So everyone has access. Anyone who might want to make a referral has access to make a referral. And then we also onboarded a number of our community-facing programs to receive referrals from our community partners. And then we have a small team of us who are very engaged with the Unite Us team, the VHHA team, the Virginia team, and our community partners to build up the network and the partnerships. We all know how complex navigating healthcare and social care can be. In our community clinics, there's almost no one who doesn't have a social drivers of health need. And we know that those needs create complications because of delayed care, because of mental health needs. And so by having this seamless connection to our community partners, because it's a health system, we can't do everything. And we don't want to do everything. We want our community partners to be successful at what they're best at. So we can now share patients. We can have folks be able to see their entire journey and make sure folks in the communities that we serve get what they need from both health and their broader wellness. Internally at Inova, prior to Unite Us, which is probably true for most folks, there was sort of a cobbled together model for getting folks into the community. When it comes to programs that have community health workers and social workers, it's a much more robust interactive process. And then in places like the emergency rooms, it's really printed lists that have been around for ages in a dusty corner, potentially. And so having Unite Us available to everybody means that I've said before, if the last thing that I get credit for is to do away with fax machines forever, I would be a happy camper. How many different organizations, one of our CHWs might be referring one patient to 4 different organizations. They have to fax the housing organization. They have to call the transportation organization. They have to send a form to the food organization. So being able to do that all at once obviously saves our team's time. But also now there's data available for our nonprofit partners to be able to illustrate the need and illustrate that they're addressing it, apply for more grants, build up a better network, and just more partnership overall. I love to operate in use cases. Writ large, we have team members all over the system referring to partners throughout the community. There are specific situations that has been instrumental in. For example, we have a organization, it's part of Inova, but acts as a nonprofit that engages folks in the community to sign up for Medicaid or access financial assistance. We also have primary care clinics, both that are safety net clinics. Inova cares at Inova. We also have federally qualified health centers and free clinics. The folks doing the outreach to the community, we're creating spreadsheets and emailing them and who's got what HIPAA things arranged and how are we communicating all of that. And now all those referrals go through Unite Us. I can, as the sort of super user at Inova, I can see the success rate. I can see that all of the referrals coming into our Inova Cares clinics are being accepted within a couple of days by our community health workers. Appointments are being scheduled, and there's no missed opportunity. No one falls through the cracks. There's no, I didn't get this week's spreadsheet, and so those folks didn't get help. We can see from our community partners doing the same work that they're now referring into those clinics and our FQHCs and our free clinics. And really, my passion is medical homes for all. And we're seeing this kind of close that gap, which is really exciting. I would say right now we're doing largely process evaluations. So we do full audits of our rejections, of our hanging referrals, and we work directly with our local Unite Us team to clean that up. So through the process work, we're really getting to where the network is nice and neat and clean and responsive, and everyone's getting to where they're getting what they need. So now we're ready working with our analytics team because we also do universal SDOH screening. How do we put the two together? We've had some fabulous interns start doing some aggregate analysis on that. But I think the big picture, we're working with one of our food banks where they're going to capture additional data when they reach out to folks we refer. And then we'll be able to potentially look at that list of folks, look at their A1Cs or look at their overall health outcomes if they're still being seen at our programs, and be able to, in an aggregate way, communicate with our partners that this is what our SDOH needs are looking like. This is what you're doing about it. Here's where we could partner more. What I would love to see, and I think we're headed in that direction, is that your social needs, your social drivers of health, are as important part of your care plan and your care management as your physical or mental health, that they all play together in one sandbox, and that the one continuum of this work is someone is screening, someone is seeing a need, someone is identifying that need in the platform, and a partner is addressing that need, and that patient then comes back to the hospital or back to one of our clinics better than when they started.